So again, the number up top is 205-846-3112. And we're going to be using this number throughout the hour. So best to kind of get that number in and then kind of do a little virtual interaction with everyone. And you get to see the live results. So surprising, but probably not expected, depending on where we are. Navigation 100%, I may be more of the minority. We're trying to use it in most of my cases. I think there are a couple people who have never heard of navigation, which is interesting as well, but somewhere in the middle, definitely most of some cases. And so as we move on to the next question, for those who have used navigation, how many cases did you do before you felt comfortable with the technology? So number one is immediate. So I was born to navigate. Text number two for less than 20 cases. Text number three for a while, 100 cases, very conservative, very conscientious about your work. And then four, I trust navigation as far as probably you can throw the CT scanner. So this is an interesting bar graph that we'll come back to later in my talk. So let's go on, Alexis, to the next slide. So we'll go on to there. So in 2007, we acquired the mobile CT scanner. I've been the flip the switch guy. Everything I do, I try to incorporate navigation from deformity, MIS, cervical trauma. And more recently, we've piled in a robot. We acquired this particular one, which I can't say what it is. But the tale of two cities is really navigation 10 years ago. There was no extensive training program. And quite frankly, as a fellow with Pat and Bay and a lot of other folks, it was really on-the-job training. And I think the understanding was that it was considered like any other fluoroscopy imaging, not too hard. How hard could it actually be? So as a sideline, the highlights that we've done with navigation after working through the learning curve and perfecting our workflow, here's an occipital cervical case of Pat and mine, a complex patient with clipophile deformities, previous surgery, decompressions, cranial settling, requiring not only a complex decompression, but certainly a stabilization, some kind of reconstruction. And when you, before navigation, or if I weren't to have navigation, I don't think this case would be done in my hands. But to be able to not only perform the decompression, get stabilization, those are that's the longest C1 screw that Medtronic makes. And then C7, C6 and 7 pedicle screws. Definitely a highlight of how navigation was enabling for me. This is another success story of mine, C2 to 7, previous fusion 10 years ago. And gradual chin-on-chest deformity. And if I go back to this, one of the highlights I remember of this case was we put it in, the patient in Gardner-Wells traction for 1 week preoperatively or prior to surgery. She was admitted for this because there was just no access to the ventral portion of the spinal canal, or vertebral bodies, and so slowly over time we got her somewhat to a reasonable position where we could access. And ultimately getting instrumentation above and below, lateral mass screws, pelvic pedicle screws, so in the middle, able to get a pretty reasonable correction that was quite successful. But again, with navigation, I wonder where we really could have achieved it. Another part of my practice that I focus a lot on is adult deformity. So here's our patient that comes in with a large thoracic and lumbar curve, both greater than 60 degrees, and relatively balanced coronally, sagittally. And all these are kind of the cross sections showing how rotated patient is in terms of their anatomy, and the difficulty with accessing those pedicle channels. And even in the hands of gifted surgeons like Linky and Ron with freehand, that would be quite daunting to say the least. And what I remember in residency and a little bit in fellowship too is how we used to skip a lot of levels. I think I was taught Apex 1 on the convex side, try to get what you can concave, and kind of do our best with that. And ultimately, with navigation, the implant density has been shown to not only improve your curve correction, but this is a patient who, these slides are a little old, but over 5-6 years of follow-up, still maintaining good coronal and sagittal correction, all with navigation. And then taking this to MIS TLIF cases, where we're able to position our incisions, implant our interbody grafts and our screws in a pretty quick and reasonable fashion. Extending that to MIS navigated scolies, where we stage it and we do anterior laterals from the front, followed by posterior perc with navigation, pelvic screws. And then cases that Pat and I get excited about also are these big metastatic sacral tumors. This one requiring, I think this was a renal cell carcinoma, and this one requiring a near total sacrectomy, complex decompression, and then reconstruction with three pelvic screws bilaterally on either side, a transbar and extension, lumbosacral reconstruction. So navigation has definitely taken us to a place where it is helpful. And over 10 years of working through that learning curve, there's a lot of lessons that I think some of the speakers here will, the moderators here will attest to. Workflow was not in our vocabulary 10 years ago. I remember when someone first brought it up to me, I had no idea what that meant. And it's that surgeon thinking about every aspect from the surgery to the patient, to the positioning, to their team, in order to minimize these disruptions. And a lot of talks have centered around that. And that's led to a lot of efficiency, not in the OR, which translates not only into time and cost savings, but also to really deliver spine surgery in a standard way. So that as we go into the future and we try to grade ourselves and try to figure out what's the best way or what's the best surgery for a patient, to be able to reproducibly do this, navigation has been instrumental in standardizing that process. So again, that workflow sense that we learned as we introduced this new technology into our OR, the realization that that navigation was more than just fluoroscopy with a surgeon and a radiology tech. It involved the navigation tech, a whole host of individuals, and really a team kind of proficiency that made it successful. If we didn't pay attention to workflow, and this is a part of the learning curve that we learned as well, we studied this at Cedars, and this publication is coming. We learned that there was issues with these things called workflow disruptions. They were missteps along the way, steps in the procedure where it took longer than it should because of the particular technology demands. And every little step along your surgery, as these workflow disruptions continue to accumulate, it led to negative impacts, either what was classically seen as slowing me down, and so we heard nationally a lot of surgeons abandoning the technology because of these time delays. It was too fussy, or even more importantly, leading to pretty disastrous clinical outcomes that affected patient safety. And I think that's the kind of a kind word for learning curve is that it really, the patient was the ultimate one who took the brunt of the cost. And that was one of the biggest things that really hit home to me, that I wish not to repeat as we continue to adopt new technology, and new technology is coming. Learning curves from navigation, as various papers did publish, we learned ultimately then that it wasn't quite the general surgery standard learning curve where the more you do, the better you get. It ended up being a little bit more complex than that. What learning curves with navigation showed us is that there are different curves that are happening at the same time. The accuracy learning curve was pretty static, whether this was a study from Horseballing in Germany, but whether you did 0 cases or 16, you remained pretty accurate throughout. But the things that did change as you did more and more cases was you became faster, the exposure to radiation, the EBL, that all significantly decreased. And so what we ended up finding is this learning curve was a lot different with navigation. There was an initial adoption of accuracy, which most surgeons were extremely happy with. The fact that they can actually see 3D anatomy, deep bony anatomy. But as they started to add more complex cases, deformity, tumor, and other multi-levels, there was issues with workflow and coordination and trying to get everyone on the same page and training everyone. And ultimately, if you didn't master this workflow, you discarded the technology and basically said to heck with it. But if you kept working on the workflow and you kept understanding the things that were in place, you ultimately achieved a proficiency in adoption that was essentially better and probably better outcomes than when you first started. As we go back to that original audience response question, I think it accurately kind of depicts where people have been on this learning curve. And initially where you think that you're pretty good with it and you haven't done that much, that learning curve is towards the beginning. And the folks who potentially don't want anything to do with it, that's number 4, or who are still working on it and achieving 100 cases, they tend to be on that second half of that learning curve where this is really the point that you want to get to, is where you've been through it and you've made all the mistakes. But again, I kind of highlight the fact that it came at a cost. Alexis, so you take us to the next slide. So bring on the robots. December was when we acquired our first robot, so we're pretty fresh. And as we try to understand how to adopt this new technology into our ORs, what we realize is it's not going to be winging it. The first question I have, again, the number is 205-846-3112. We'll be using this throughout the hour with various case presentations as well, so hopefully you all have the number now. Again, to understand the audience, who's using robots? Have any of you used it at all, or is it price prohibitive or cost prohibitive? Are you using it some of the time, all the time? Are you distrusting of it and want nothing to do with it? So let's see where our group lays. And so this is kind of the results I expected. I think nationally there is an adoption that is happening with robots, but the vast majority haven't. And they're kind of in our position where we're trying to figure out if it's right for us or not. And once you do acquire it, how to do it safely and efficiently and kind of not impact your overall workflow. So let's, Alexis, if you can go back to the next slide. And for those who do use robots, let's see, go to the next slide there. That's the next audience response question. Alexis, if you can go to that audience response question. For those of you who do have robots, do you, let's see it pop up there. How long did it take, just like navigation, how long did it take before you felt comfortable using it? Was it immediate? Was it less than 20 cases, greater than 100 cases? There's probably not that many individuals out there with 100 cases. And then or I don't trust robotic technology because I've watched the Terminator. And so, okay. keeps shifting around, but it seems like the standard learning curve of less than 20 cases, or a good sense of concern about whether to trust robotic technology. So that's, I think this kind of really accurately predicts. Alexis, can we go to the next slide? It shows us that we're talking to an audience that is all over, and in a good way, people, experts that use it and experts that don't. But one thing that we can't deny is that robotic accuracy and robotic technology is not leaving. It's going to grow. Just like at some point in '07 and '06, everyone thought navigation was going to die. The technology survives because study after study that gets published by even some of the moderators here, the accuracy remains pretty high. And the value of instrumentation accuracy, the value of standardizing your delivery of instrumentation in the spine to your patient is paramount. And so these technologies should not be abandoned. They should actually be embraced and continue to figure out how we can incorporate it. And what all these meta-analyses of thousands, hundreds of thousands of screws show is that clinically it leads to decreased complications, decreased revision rates, decreased intraoperative repositioning. And so it really does translate into meaningful difference. And it's being used everywhere, whether it's Nick Theodore doing short segment fusions, Jeffrey Gum using mid lifts, cortical bone screws, MIST lifts, single positioning, whether you're using it, they're using it now in cervical for augmented virtual reality, endoscopic with Mike Wang, he's using robots with that, or even tumor. It's slowly pervading into all aspects of what we do, so it isn't really limited to one thing. And so what is the learning curve in the literature? And there are a couple studies, not that many as much as navigation, but one of the first studies, if you talk about robotic learning curve, you can't go without looking back at the work by Dr. Lieberman. I mean, this was 10 years ago as we were just futzing with navigation. He was working on robotics. And one of his studies that commonly gets quoted is from 2010, over a decade ago. And in his patients that he looked at, and Izzy, by all means, correct me if I'm misquoting you, but as he grouped his 150 patients into 5, he looked at an earlier generation of robots, but still robot technology nonetheless, an 8% bailout. And from what I gathered, that was literally bailing on the technology, abandoning, moving it out of the way, and converting back to your usual workflow. And that seems high and concerning and kind of reflective of what we saw initially with navigation. As you did more, your abandonment decreases, your accuracy improves, your reliance on going back to fluoroscopy or freehand decreases, and ultimately what he found was that in the standard learning curve, anywhere from 30 to 45 cases, that's where you see. And so we go back to that general surgery learning curve where maybe, just maybe, the more you do, the better you get. What's interesting is I looked at the 2019 to 2020, so last year's work on more modern robots that are a little bit more semi-autonomous, that are self-registering. And this is a study out of Australia, and they looked at 80 patients, 352 screws, divided again into those 4 chronologic subgroups. And what they found was the time per screw, the efficiency with which you do your surgery, whether it's the first case, first patient, or the 80th patient, it doesn't seem to change. It's a pretty flat line. And then when you look at the screw revision rates, the misplaced screws, the complications, this all turns out to be not significant. So a little bit different take in the literature 10 years later on these newer robots. Mike Wang, who I've talked to at our conferences, he did a little study on residents and fellows and how they compare. And whether you're a PGY1 or a spine fellow, the accuracy, the time per screw, not statistically different, whether you do 1 case or more than 7 cases. And then John Polina in Buffalo looked at his learning curve with more modern robots and found that, again, time per screw, fluoroscopy time, radiation time, there really wasn't a significant difference whether it was the first 10 or the later 100. And so ultimately what we're seeing here is that maybe the learning curve for robots is different. Maybe it's more linear. And certainly all it takes is one person to be really accurate or really well-versed at robot technology that can immediately transfer to a trainee or a new learner. And that's appealing. That's different from navigation, where it was hard to kind of transmit that information and that workflow experience to a junior. But maybe the robots are different. So how do we flatten the curve? At Cedars, we, Johnson, myself, Dr. Bay, everyone kind of recognized that there's an opportunity to accelerate our learning curve. And we went to the manufacturers and we formed a little bit of a pilot program. And this is what we did with this new technology. We all got used to that preoperative software. It really got us into the brains of the robot, how to position the screws, how the robot was going to think about putting screws in, spend an afternoon, all the preoperative planning that seems to be an emphasis on robotic training. So a lot more thinking about the case before the surgery. We learned the tricks of the trades. We assembled our best team, our youngest scrub techs, the ones who were energetic. The manufacturer also has a robotic specialist team that they provide. So you set yourself up with the best team to achieve the success in order to guarantee it. And one thing that we did with a lot of our surgeons is if the case was happening on Monday, on Friday we ran through a dry run. So all the anesthesiologists, the exact scrub tech, the exact nurse, the assistants who were going to be present on the case, we took them to an empty room. We had a true trainer. We ran a navigation spin, and we worked on instrumenting the pedicles with the robot in our hospital, working on our specific workflow, because everyone's workflow is different. And we went through disaster bailout plans. If the robot started doing one of these things where it just, the arm was moving out of control, if it's detached, if we got catastrophic failures. And that was helpful to run the team through all those things. A shout out to Martin Pham at UCSD. We went down to his cadaver lab and really kind of, Pat took a while and grabbed the robot and just shoved it back and forth to understand its tolerances, and really understood incisions and where to put our pins and work on the concept of skiving. And then we had a visiting robotic expert who came and ran through my cases, at least. I asked him about his worst case scenarios, so a little bit of details before the day of surgery. And ultimately, first case, excellent, good results. Second case, excellent, good result. 15 plus cases, now 3 or 4 spine surgeons that are using it, all going very smoothly. We're not seeing that abandonment because we would know, and we think that there's a lot of value in thinking about things before surgery, having the experience with navigation, which was truly a high, it took a lot to figure out, and the importance of a positive energy team mentality, getting people excited, and certainly there are these model training programs that we're trying to roll out across the country to really adopt this technology and get us to point B instead of a point A, because the difference between point A and point B are a lot of patients that get hurt. And so when we talk about at the end, what are the future studies, what is really the special sauce to flattening this curve, I think it's pretty apparent as any type of new technology that will come in, and who knows what it will be after robots, the surgeon champion. But the surgeon champion, not so much as, yeah, I'll do it, but hey, let me think about this. Let me pick my cases clearly and kind of work through that whole process. Having a navigation background for us was extremely valuable, because that helped us accelerate the team and getting them proficient. And then utilizing the concept of a linear learning curve of people who are already experts, and them able to transfer it to others seamlessly. And the impact of these next generation operation robots. Right now, they kind of register automatically, they move, but they don't actually put the screws in. But as this continues to get, they're cobots, right? As they continue to get better and more autonomous, is that going to make it even easier, or is that going to introduce its own problems? So again, thank you very much for hearing my talk. Just something I've been thinking about for a while now with all this new stuff coming.
Terrence, great talk. Always so thoughtful in introducing new technology, and you've been a pioneer at Cedars. And I think certainly in the beginning there was a difference between navigation with TK and navigation without TK. As you taught us how to get through that learning curve. And you might want to do a study in that regard as well. But we did have a question, and I think this is pretty interesting. It's kind of the question of, what happens when you abandon or you can't use navigation? And I think, that's kind of the issue. So, now that you've used navigation continuously, what would you do, let's say, in a lumbar case, let's say it's a deformity and you don't have navigation, O-arm is broken. For you now, would you cancel the case? Would you reschedule the case, or would you proceed? That
actually has far-reaching implications, especially as we train, as you and I and all of us train fellows too, is to understand that you can't just be navigation dependent. And then there's reality too, where on the weekends, after 7 o'clock, there's no navigation support. And so there's always a healthy understanding that you still have to go back to the basics and understand. You still have to do open deformity and understand anatomy. And so we're well supported. So even at 7, 8 o'clock, I can kind of convince a navigation technologist to stay and help me run it. But if they truly don't exist, going back to fluoro and the way, or the way that we normally do, or we're trained to do, I think you can't lose it. These are all enabling technologies, and some of these moderators have mentioned that it doesn't make a bad surgeon better. But it is a cool technology that I think really gets you to a level of performance that's better than when you started.
It seems that one of our attendees, I won't give his name out because he's saying that his attending abandoned 2 times because the arm wasn't working, just abandoned the case. And I think that that's kind of what I worry about too. I mean, there's no question mentally it's so much easier. It's like the decompression becomes more difficult, right? The screws become kind of much easier. There is another question about mental fatigue in the robot. And, the question is that, do you feel that, with the robot, do you have less mental fatigue or more mental fatigue? Because you're, doing issues with the robot. Like, what do you think for you, Terrence?
So in the most kind of respectful way, I'm going to bow out to this question because, again, I've done 10 and I have my own thoughts, but I think there are a couple speakers here that have been using the robots more. And Izzy, I'd like to hear what you think about surgeon fatigue.
Are you less tired with the robot? I mean, so for you, Izzy, I think the good question is, do you always, for let's say more than 2-level fusion, do you always use the robot? And I want to ask Terrence the same question. Does he think he's going to ever get to the fact where he would always use a robot like navigation?
I know, Dr. Vaccaro, don't you use the robot?
Yeah, we can hear you, Alex.
I do 1 robot case a week. So every week the fellow chooses the robot case, and I could care less what he does. And he's got to make sure we have the preoperative CT scan. He has that all worked out. So there's 3 different ways, the mechanisms. We could use the fluoro for the robot. We could use the intraoperative O-arm, or we could use the preoperative CT. I use the preoperative CT, and I know that adds extra radiation, but my workflow is easy. So I make it my second case of the day, and I have it down. I felt the companies that supplied the robots never really spent time working on workflow. So initially I didn't like all the little stab wounds. I thought that was a pain in the neck. So what I do is I make a central incision, and I'll actually pull the skin over and I'll undermine the fascia and I'll put my percutaneous screws to the fascia, sort of like an MIS strategy. If the screws are really anatomic and they're really far lateral, I'll make percutaneous incisions. So I developed a more relaxed attitude. So initially I was frustrated because I have ADD. And then over time, I got to be really, really relaxed. Like I know how to hold the drill. I mean, you have to look out for skiving, all the little things that happen with the robot. And after a while, it just became second nature to me. So the robot case now is a simple case that I do, and I really enjoy it. Now, during the COVID crisis, the last 2 months, I haven't used the robot because they would murder me for doing elective cases when I'm not supposed to. That was a joke. I can go and laugh.
Alex, which robot did you use?
Come on now. Where's the
Alex, which robot did you use?
Don't use the robot during the COVID period. But now that you're out of the COVID period, I'm going to start using it again.
Alex,
why would you pick one case a week and not use it all the time if it's low stress?
That's right.
Because I have to be there, because I do 2 rooms and I have to be there for the whole robot case because of, I just got to make sure everything goes right. Because, you walk in the room, the way I do my case is I walk in the room, the fellow sticks the fiducial, the two pins in, and then he does a spin, and then we, align the vertebral bodies with the preoperative CT scan. And then once that's done, they let me know in the other room, and then I come over. And the robot portion of the case is really fast. And then I put the screws in first, and I do my decompression. So then I could, yeah.
I'm sorry, but for Alex and everybody else except for Izzy, what robots are you using? We know which one Izzy's using.
I use the Globus. I use the Globus.
Okay.
Razor.
And which one?
I use the Globus.
Okay.
Amazing.
We have it's the robot that rhymes with razor.
Mazer. That's Medtronics.
Terrence, same one. Terrence, the same one as well.
We use a Mazer.
Yeah,
we have
myself and Johnson, we all have the same robot.
Yeah.
Is there any opinion among the robot users which one seems to be more advanced at this point?
So I know Izzy loves. Izzy's microphone working yet? It's not It's not working. So
It's perfect.
The,
You can say whatever.
we have both Medtronics and I have the Globus. I think the Globus is easier because it has navigation. It's simple. My partner uses the Medtronics, and I think there's more steps. And I watched Izzy do the Medtronics a couple of times. I thought there was more steps than Medtronics. I never used it. I think the Globus. Oh, he's on his telephone.
Yeah. Let me ask another question. So for the guys that do the big multi-level deformity cases that also require decompressions, and I've operated with Izzy, and he's very facile with the Masonics and doing the decompressions with the Masonics versus the burr versus standard Kerrisons. Are you guys using new technology for multi-level decompressions as well when you're doing these big deformities?
Who are you asking that?
I think
Anybody. I mean, we're talking about new technologies, and obviously with multi-level decompressions, there's a time factor to it if you do it kind of the old-fashioned way like we were trained 30 years ago. But with the newer technologies like the high-speed burrs and the Masonics, I would just like to hear what other guys are doing.
I would say that I was always like, this O-arm takes too long, navigation takes too long, I'm just going to do it this way. I'm really good with the AM8, I don't need the Masonics, but I've changed. Now I'm like, I want every technology that's going to help me as possible. Like, bring in anything, bring in Masonics, bring in the robot, bring in everything. Because, it's amazing. After you get to a point where, you realize like, if it's really helpful and there's a safety quotient, why not do it? And then I think
what's Masonics? I never heard of Masonics. What is that?
Masonics is the ultrasound.
Masonic is the ultrasonic bone scalpel.
Yeah, bone scalpel.
Okay.
Yeah. Now, Eli,
I think, and I think.
Yeah, Eli is dying to ask a question. I don't know can we unmute Eli, because Eli's requesting to ask a question to the audience.
He's raising
Eli,
it.
oh, he's coming in. I see him.
I've been in countless amount
Oh, Eli comes. There he is.
Oh, there he is. Okay, Eli.
navigation cases at this point, and I've been with you, Terry, in the OR where we'll feel something is wrong and we'll stop because our tactile feedback, something looks slightly off. I'm worried watching the robot work that we don't have that level of right in the face of the screw going in, and then all of a sudden our screw is pointing past the spine, we pull it out, and now we have a catastrophic bleeder. How do we prevent that from happening with a robot?
Terry, that was it for you.
Eli, yeah, that I think that's a big problem with robots when you first start is you lose a little bit of control. That tactile feedback, but the concepts of how it registers and how it is intrasegmental, so it really uses the actual bone anatomy with the CAT scan to register instead of this alignment, which is what navigation was. So if you bump the patient, you lost registration pretty quickly. It takes a little time, just like with navigation, to really trust it and to get it through. But I do worry about those cases, and I think that's why I use them more open initially. The MIS ones are the ones that you can really get into trouble. But I think that's something that is something that, I don't know, I really feel like we can get over and potentially understand that the robot right now is absolutely not exciting. It's a cobot. It just holds things. And so really what we're investing here is the technology of the future. These robots that could potentially do multitasking, and truly autonomous, that's what we're striving for. We are at generation like 1. And so that's why right now you adopt it, you kind of understand it, and all the things that, Scott, you were talking about, the benefits that and things that it could do while you're focused on something else. I think that's the true promise of robotic tech, and to do it kind of in a very standard, accurate way.
Terrence, just a follow-up to Eli's question, and I think it's really for you and Alex. I think Izzy's probably beyond it, but do you hold your breath for the first screw or so, not knowing whether your registration's right, and then relax after that, or does the anxiety never stop? Or do you trust it so implicitly that once everything is set, you're on you're on instrument flight rules, and you close your eyes? So does the first screw still kind of make you sweat?
Yeah. So when you first begin, you feel that way. After you've done it for 4 or 5 months, I don't feel that way at all. You see the angle, topographically, you have an understanding. A more obese patient, you have less of an understanding. You feel with your drill, and it's a way of feeling. And you have to, when you have the drill, like the striker drill, you weight it in a certain way so it spins. I mean, it's all intuitive. You feel the drill in it, and you can guide it the way you want to do it. So after a while,
you trust it.
Yeah, I trust it. I trust it implicitly.
But you know, the one thing that we're missing.
Well, can I just make a comment, because I think
Oh my God!
Great.
We can hear you.
Sure, we'll let him make the closing comment.
Oh,
so
he's got audio.
To silence me. But all the comments are valid. All the comments are concerning comments. Terry, you did a great job bringing all the salient points to bear. The one thing that I do like to emphasize every time we talk about robotics and navigation is that robotics and navigation are not going to make a bad surgeon good. You still have to know the anatomy, you still have to have the feel, you still have to have the indications for surgery, and these are tools that are going to make us more efficient and more precise over time. We still do the surgery. It's not the robot that's doing the surgery. So as we develop this, we just have to keep that in mind.
All right, fantastic. I think at that point, we will move on to the cases. That was a great last statement.
Today, I'm presenting a case of a 58-year-old male who originally presented to another facility and saw another surgeon about a year ago with complaint of upper extremity weakness, loss of hand dexterity, along with some gait abnormalities. His left biceps was weak. He had grip strength weakness, no neck pain, and no significant past medical history. His plain radiographs, as shown here, dated January 2019, are shown. revealing of diffuse degenerative disc disease. There's a grade 1 C3-4 spondylolisthesis, some evidence of congenital spinal stenosis. Unfortunately, we didn't have any flexion extension views as these were done elsewhere. MRI dated March 2019, revealing of cervical spinal stenosis, most severe at C3-4 and C4-5. Given his progressive myelopathy, this other surgeon recommended surgical intervention. This is where we wanted to poll the audience. So if you guys could text that number. Yep, can we go to the next slide? Given his condition, his progressive myelopathy, who would consider going posterior, doing a laminoplasty, laminectomy, going anterior, doing ACDF, who would consider doing ADR, and who would consider doing front back? All right, so majority says ACDF. All right, we can go back to the PowerPoint. So again, I wanted to reiterate that this was done elsewhere, and this is what this patient ended up getting. He got a 2-level ADR at 3-4, 4-5. Unclear as to why he got a pro disc at 3-4 and then a Mobi-C at 4-5. Nevertheless, postoperatively, he did well for about 2 months, reporting slight improvement in symptoms. Unfortunately, thereafter, he developed worsening of his hand coordination, some tingling to his hands. Again, no neck pain. And then in the month leading up to seeing us this year, he developed worsening of balance and gait ataxia. On exam, he had bilateral Hoffmans. He had 4 out of 5 grip strength, intrinsics, and he was unable to tandem walk in tandem gait. MRI was obtained in February this year, which was difficult to assess given the amount of artifact from the artificial disc replacements. Unfortunately, he reported to our emergency department on March 13th of this year, now complaining of urinary incontinence and increasing gait abnormalities. He got an MRI of his thoracic spine and lumbar spine, which were revealing of mild degenerative changes, but no significant stenosis or cord compression. Additionally, he got a full urology and neurology consult, which didn't reveal any other underlying condition that would explain his urinary incontinence. He got a CT myelogram, which did appear to reveal residual stenosis at 3-4 and 4-5. Interestingly as well, at C3-4, the bilateral facets were revealed to be fused. And that's the level where he got that pro disc. So at that, correct. I want to reiterate that the index operation was
it was Rod Akasuian.
Yeah, this is his greatest hits.
Down.
I referred the case down there. Here.
So given his condition now with his worsening myelopathic symptoms, now with urinary incontinence, wanted to poll the audience again to see what sort of treatment you would consider. How many would we go to the poll there? I'll also mention that he saw another surgeon prior to seeing us who recommended revising the artificial disc replacements, who would revise the fusion, who would do posterior only and do a laminoplasty or laminectomy, who would do a front back.
Rob, I have to just ask a question. Does he have much neck pain from the beginning? Did he say
no,
that?
Minimal neck pain.
Okay.
Typical aches and pains,
Okay.
But no significant neck pain.
Okay.
All right.
Looks like a posterior laminectomy.
So,
laminoplasty seems to be the majority.
The majority. All right. Can we go back to the PowerPoint now? And so this is what we did for him. We did C3 to 6 fusion, all anterior, did a C4 and 5 vertebrectomy, removed the 2 artificial discs. And we did get a postoperative MRI, which reveals adequate decompression. Interestingly, there was increased cord signal change at C4-5, which led us to believe that there may have been a dynamic process at that level. Postoperatively, he did well. Immediately reported improvement in his hand tingling, hand coordination, increasing strength of his grip and intrinsics, improved balance and gait. He had 5 out of 5 strength throughout, and he was discharged on postoperative day number 2. Right now, he's about 6 weeks post-op and reportedly still doing well.
Yeah, I think that this is an interesting case, and I'd love to see Pat.
I think this is kind of the jeopardy of arthroplasty. And again, this is not my case. It looks like Bay is having some difficulty getting logged back in. But, I think last week, Pat and I and Bay were talking about how the history of lumbar arthroplasty, and, credit to the TBI guys, very kind of straightforward, methodical. And publishing on these results. And what we see is, for example, in LA, and I'm sure it happens elsewhere too, someone put an arthroplasty in at a level that was already fused, at 3-4. That means to me that no preoperative CT, no real thought to kind of the indications, and just because it is the latest and greatest thing, it doesn't necessarily have the problem, or it is the right surgery for him. But when I was talking to Bay about this case, that 4-5 spinal cord signal change that was an issue, because I think he felt like there was a lot more mobility, something very not right and unstable going on.
Yeah,
it was also an arthroplasty that traditionally is not thought to be more constrained.
Okay.
And so there was a little medical legal going on. So he wasn't about to do anything that would destabilize the spine in the back. In terms of a laminectomy or a laminoplasty. And quite frankly, I think he was looking to, and he definitely wasn't looking to replace the arthroplasty with more arthroplasty. I think everyone had a little sour taste to that. So I think the only solution was left for an ACDF.
I don't know if you guys can hear me, but I think this is the case where typically, I've done a lot of myelopathic cases with arthroplasty, and I think Pat has too. But this is an interesting case. There was really not much evidence of stenosis, even with the CT myelogram, but his presentation, his clinical presentation.
I think Scott, did we lose you, or is that me?
No, I'm here.
Oh,
can you guys hear
me?
Did
you say something?
Yeah,
I thought someone called my name.
Oh yeah, I was going to say, Terrence, I think you hit it on the head. We're doing preoperative CT scans on all our arthroplasty evals, and if they had fused C3-4 facets, there's no way we would do an arthroplasty in the face of fused C3-4 facets. And then I think Bay brought up earlier, you didn't have them, but if there was instability on flexion extension, that's definitely another contraindication. So what you guys ended up doing was, the right operation that should have had in the first place.
I think the interesting thing, and I'm not sure who can hear me, is that this is probably the one case that I felt.
Rick, do you have anything to add? Or?
That motion may have contributed to some of his myelopathic symptoms.
Rick, Jack, Izzy, do you have anything else to add to that?
Yes.
I do want to go on to the next case presentation. I'm not sure if you guys can hear me or not, but I'm just conscious of time.
I think we can all hear you except for Terrence.
Everybody except Terrence.
Okay. All right. Okay. I think
is that what happens at home as well?
Can we go to Lindsay if you're up?
Lindsay, can't hear you.
Lindsay can't hear you? Okay. Blake.
Hey, Bay, did you back that case up, or is just the anterior alone?
No, it was only anterior alone, but it was a 2-level. I mean, it's 1 level was fused, right? So the 3-4 level was already fused. Yeah, naturally.
So before we go on to the next case, I mean, does having an adjacent segment fusion exclude this patient from having some motion preserving procedure? Okay, I don't agree with the artificial discs whatsoever. Okay, I think that was an ill-conceived and poorly executed operation.
Well, it was. I mean, on flexion extension, they should have picked up the fact that he had no motion at the level they put one. And the other thing, he didn't do an adequate decompression.
Right. There were a whole bunch of things wrong with that.
Yeah.
Case. That's why I said.
I think the 3-4 level, he put artificial disc in a fused level and then didn't decompress the canal, which is the primary thing you need to do, right?
I think the patient needed some other operation from the beginning, and there's different options. But
yeah, I think
Hey, Lindsay's back. Lindsay's back. Put her up.
Yeah, move on.
Let's go. Oh, okay.
Great.
All right, Lindsay.
All right.
Okay, good. Hello, everyone. I'm glad my audio is working now. I'm Lindsay Ross. I was a neurosurgical resident at Cedars, and I'm doing my spine fellowship there, and hopefully will stay on after the fellowship's over. So right now I'm just going to talk to you about a Dr. Kim case. Okay, so SM, he's a 48-year-old male who previously underwent an L4-5, L5-S1 laminoforminotomy decompression in 2018. He did very well from the procedure. 1 year later, he was lifting and moving some heavy boxes in his garage, and he presented with severe axial back pain and then contralateral left lower extremity radicular pain. The pain was worse with the extension of the lumbar spine, and he denied any bowel or bladder changes. Here's an X-ray of the lumbar spine that really showed L5-S1 degenerative disc disease and L4-5 to a lesser degree. Thanks. So he returned to our clinic 6 weeks later with actually worsening pain, and now he had bilateral radicular pain. His pain was very severe when standing upright and when twisting. So here's his MRI that again shows degenerative.
Uh-oh, we're losing it.
Uh-oh, we lost you, Lindsay.
DT of the lumbar spine that shows the previous defect on the right side at the L4-5 and L5 levels, but also shows a pars fracture at L4-5 on the right. So the patient was sent for SNRB at the L4-5 level with temporary relief. We tried to brace for him for 2 months without relief, and he really couldn't complete physical therapy due to pain and actually stopped working. And he was very anxious about returning back to work. So we have a patient who has an L4-5 right-sided pars fracture with bad back pain and severe bilateral lower extremity radiculopathy who's failed extensive medical management. So at this point, what is your surgical option of choice? So here you can text in your options. Number 1, L4-5 lateral lumbar interbody fusion. Number 2, L4-5 transforaminal lumbar interbody fusion. 3, L4-5 ALIF, PSF, or number 4, L4-5 posterior spinal fusion without antibody. Okay, great. I pretty much have a consensus that most people here in this presentation right now would perform a TLIF. Some would do an ALIF. Surgical option of choice. Here's another question. What technology would you use for instrumentation? 1, an intraoperative CT with navigation. Number 2, robot assistance. Number 3, if you would use fluoroscopy. Or number 4, just freehand, we don't need no stinking guidance. Oh, wow, okay. So it looks it looks like we're pretty much even with respect to navigation, fluoroscopy, and freehand. And that's Dr. Kim's one vote for the robot. 2 votes.
Two.
Lieberman.
Okay.
Lieberman voted for the robot. I
Was that
guarantee you.
Lieberman's vote?
No.
Oh yeah.
T-lift, yes.
Okay.
Thumbs up if it's.
All right, next slide. Okay, opted to do L4-5 T-lift, minimally invasive T-lift with robotic pedicle screw insertion, posterior spinal fusion. We did bilateral Wiltse approach and placed and tried to do the T-lift through the Wiltse approach on the left. We were able to move the facet, and we saw the L4-5 nerve group. And we also encountered an anatomical variant of the L5 nerve root where it was exiting more cephalad to normal. So this didn't allow us to continue on with that lateral based approach, and we had to move to a more midline open approach on the left side and do a full laminoform anatomy. There we encountered a small durotomy, which was likely due to some of the scarring from the previous operation. The durotomy was more midline, and we closed that primarily with 6-0 proline. So we were able to retract the L5 nerve root medially and finally place our interbody graft. Then we were able to put the rods in and decorticate and place allograft, place a drain, and close the patient out. Here are some pictures. This was one of our first robotic cases that we did. You can see the mazer there. We also call it Moses, and mini Rex there in the red caps. Oh, here I also wanted to mention that the OR time was about 1.5 hours because of all the variance in approach, but we only used the robot for about 15 minutes, and the estimated blood loss was 70 cc's. So postoperatively, the patient did really well. The bilateral radicular pain resolved. The patient was full strength, sensation was intact. He was discharged on post-op day 1. On follow-up visit at 6 months, his VAS scores were 0 for back and leg, and his PROMIS scores showed an improvement in physical function and severely decreased in his depression scale, and the pain interference was significantly decreased as well. And those are post-op x-rays. That's it.
Fantastic. Fantastic. Now, I just want to get a
Dr. Kim, any additional comment?
Would anybody use one-level T-lift, a robot, navigation? Pat, would you do this?
Sure. You know, I was just actually making a couple of notes here and talking about some of the different things that I was listening to. And, you know, the robotics technology is a natural progression of, you know, some of the high-tech things we've been doing. And, you know, I've done the image guidance stuff ever since the late 90s. And, you know, when I came to Cedars, people were just, you know, what are you doing with that stupid computer? But you know what? It has become everyday use. Okay. Now, is it for this case? Can you do it, Bay? I mean, we work in rarefied air at a you know, a big institution that's supposed to do these things. And, you know, I think that doing this and learning how to do safe and methodical utilization of robotics. And I didn't pipe up and comment, but I said, after we spend all this time, and it does take a while to do it. And, you know, I commend Terry, and it was not just a great talk, but it was also thoughtful utilization. But I can tell you, and believe me, I don't bullshit about this one, but it's that I can't believe the speed of how fast, okay, when somebody's gotten good at it, and Terry has gotten good in a very short time, but the speed of putting 4 screws in is faster than you can do it with image guidance, and it's faster than you can do it with fluoroscopy. I was amazed. Okay, so can I justify that one? Yes, I can. I think that, you know, just the short time of experience we've had of looking at the robotics things and putting in 4 or 5 screws, and, you know, there's some safety things that need to be done. I think that the surgeons, when they use them, you're not going to go do percutaneous cases. I would not trust that. I have to see things. Eli asked, well, what if you put the screw? Still, you go look and you see, okay, here's the mammillary process. Here's the anatomy, you know, all of those things. No, this methodical process of doing it, but I can tell you, I've watched these guys put in, and I watch more of them than I do now. They can put in screws really fast, and I'm impressed. And I think that the technology it's kind of taken me by surprise that I'm impressed with it more than I thought I would be. I hope that answers your question.
Yeah, I mean that's the question. I mean, the real question is this going to be pervasive, just like navigation is becoming more pervasive? I mean, is this going to be the standard of care? Izzy, I just want to get your opinion. One level T-lift. Do you use a robot? All?
Yeah, I do use the robot. Can you hear me now? I
Yeah.
do use the robot for my percutaneous one-level cases. I do find it very efficient. I really like coming to the operating room with my preoperative plan. I have not placed T-lift cages. I'm still an A-lift fan predominantly. I'll use T-lift in those that aren't suitable for an A-lift, or some of the revision cases where I have to do a decompression. I'm going to be down there anyhow, so I'll use a T-lift approach. But typically it's an A-lift followed by perc screws using the robot. And it is efficient, as Pat said. But again, you have to understand the anatomy, you have to understand your technology, and you have to be patient with it. You cannot rush it for the sake of rushing it.
Yeah. All right. Well, we are running late. I want to give Blake 10 minutes. Blake, I want you to do this case presentation in about 5 minutes so we can talk about for 5 minutes. I think the last question somebody asked, obviously, is the cost of the robot and how we're going to factor that in. And I think, that's something that we're going to have to decide as well. Blake, is your audio working?
Can you all hear me?
Yes.
Fantastic. He's got a 70s filter on.
Referring to this. So I know we have limited time, so I'll go rather quickly. I might skip a few of the questions just to get to the end for discussion's sake. But I'm Blake. I'm one of the spine fellows here at Cedars-Sinai. So this patient is a 53-year-old gentleman who had previously undergone a right-sided C3, C6 laminoplasty back in either 2000, 2001. Obviously, the EMR wasn't around then, so it's hard to see. But he was doing well until 2011. He began to get some left-sided trapezial pain that had been present for about a month. On exam, he had no weakness. He hadn't undergone any type of conservative treatment. I'll show on the next few slides here the x-rays and the MRIs, but basically he had left-sided C7 foraminal stenosis that ultimately underwent a left-sided C7 selective nerve root block. So here's his x-rays. The last I could see was back in 2008. You can see on here he has a 3-6 right-sided laminoplasty. No other gross findings. MRI here shows, as you'll see later on, he has a 4-5, 5-6, 6-7 disc herniation, but most pronounced here on the left side is C6, C7 with a lot of foraminal stenosis correlating with the symptoms. Over the next 2 years, he was managed with our pain specialist as well as seen by numerous spine providers. He had great relief with that injection. He gradually, however, began to develop right-sided C5, and this is a mistake, I should say C5 and C6 radicular symptoms. He had a repeat MRI done that showed right-sided C4, C5, C5, C6 foraminal stenosis that I'll show on the next slide. It's a little dark here, but you can see pretty significant foraminal stenosis on the right side at those two levels. So this had been going on for 2 years for him. So the first question here, if we can pull up this slide, is what kind of surgical treatment you would recommend. It's going to be laminoforaminotomies for him, 2-level ACDF, 2-level ADRs, or whatever other treatment you would recommend. There it is.
Now, Rod, while we're voting, I want you to tell us, what would you do in this case?
Was there a CT scan? I missed it.
There wasn't one to that point that I could find. There's one following the surgery, but
I can see you guys trying to bait me.
I should have said pay attention.
So probably.
Can I interject a little bit? Let me interject. I mean, just a little bit.
Johnson is trying to bait me.
Is that this story actually, and Blake did as good a job as he could putting it together, because the imaging studies were in the archives for Cedars, because I actually operated on this guy when I moved from UCLA to Cedars. He was one of the first patients I operated on in 2001. And he's a holy man at Cedars-Sinai of the highest order. And he said he didn't want a fusion operation ever because he heard they were bad. And so I said, good, I think you need a laminoplasty. So I did a laminoplasty on him in 2001. And he came back about 10 years later, and I did, I think, 3 posterior cervical decompressive procedures on him, and his spine was getting worse and worse and worse all the time. And there were some CT scans shows he's got severe spondylosis, degenerative disc, and huge disc osteophytes. He's growing at every level at C4, 5, 5, 6, and 6, 7 to a lesser degree. So he has a 3-level bad neck pain, arm pain that we've treated a couple times along the way with some posterior decompressive work. So that's what you're supposed to vote on right now.
Okay, I changed my mind. I would do a 3-level artificial disc.
All right.
Wow. Jack, same 3-level artificial disc. Jack?
No, in a guy that with Pat's been in his posterior neck 2, 3, 4 times, I would do fusion on this guy, and then not worry about screwing him up with either instability or foraminal pain from his facet hypertrophy. So I do ACDFs.
Scott, Rick, ACDF, all?
CT scans to look how much facet integrity is left, flexion extension, and then I think either one is okay. If there's any question about facet integrity or instability, ACDF, I agree with Jack. I can't see that. That's really small.
Yeah, that's pretty good.
I'm trying to show you.
That's really good. That's really good.
That's very good.
How's that?
I mean, I
even took out the name to make it HIPAA compliant. It's pretty good.
Yeah, I got his name.
Yeah.
I told Blake, I said, Blake, you got to get a couple of CT scans here.
That's right.
All right. So let's see.
We got 2 more stages to get here.
No instability on flexion extension x-rays. I mean, all of his discs are collapsing, or the 3 bad discs are collapsing, and bad spondylosis and big disc osteophytes from the front, bad foramen, and we did everything we could to try and not
Blake,
fuse.
Go to the end.
Yeah, go to the end.
Just jump to. Let me go really fast. He had cited C4 to C6
Just show the pictures.
All right, I'll go to the end. Basically, he had those foraminotomies. He continued to have persistent pain, became bilateral. He underwent another set of bilateral C6, C7 laminoforaminotomies. And so, again, he began to develop significant neck pain as well as bilateral trapezial pain. Sorry, I'm getting there. Here we go. Ooh, how much ruined it. Bilateral trapezial pain. So here it is. He had an MRI that showed pretty significant right-sided C4 to C7 disc herniations. And then a CT spec scan showed 4, 5, 5, 6 enhanced signal. So going to the end here. So this gentleman has bilateral arm pain. He's undergone right-sided 4 to 7 laminoforaminotomies and bilateral C6, C7 laminoforaminotomies. He's got significant pain. So at this point, given his history, what would you recommend?
Where's Howard? Howard would say if you did bilateral foraminotomies, you would have to fuse the patient.
Yeah, there was a big discussion.
Where's Howard?
Yeah, where's Howard at?
I don't think he's on here. I looked earlier because
he's still on the floor from falling off his chair from Rod's case last week.
I want to know what makes you a Cedars-Sinai holy man.
He's a high rabbi.
Unless they have a
rabbi.
I'm guessing they have a building named after him.
You ask Pat Johnson to do your 4th decompression. That's the holy man.
Yeah, then you become a holy man.
Okay, I've since done 3 lumbar decompressions, and then he finally ended up with a portosacral fusion. So he's like an annuity.
Yes, so ultimately we got ADR in him, 4 to 7. I lost the slides, but he has C4 to C7 ADR.
Oh, we don't have the slides?
Yeah, it fell off.
Slides.
All right.
Show us the picture.
Wow.
So there's a fluoroscopy of him. And then that was back in November last year, and he was last seen, I think, in March of this year. And he's doing well. He's back to full activity. So,
awesome.
How much neck pain did he have before the
Nice
surgery?
job, Pat.
How much neck pain?
Yeah, was that
It
an
was
issue?
40%.
He did. You know what? And I'm interested, Jack, what your thoughts are, and Scott, what your thoughts are about, this idea about facet joints. Is that, when you got collapsed down facet joints, and if you look at his facet joints on this lateral radiograph, they're offloaded. And, that was a Rick Delamarter thing that I learned from Rick. And he said, you know what, you put an artificial disc into a collapsed interspace, and he said it offloads the facet joints, and the facet joints are only 20% of the mechanics of the cervical spine anyway. I'm just interested in everybody's thoughts about that. I mean,
we don't see a lot of
cases like this that have done really well. I mean, with bad problems. I've got, I don't know, I don't have hundreds of patients, but we've done enough of these that are really bad looking problems, and they've done remarkably well. I mean, I got a couple of them that aren't, but most of them are doing really good. I'm surprised.
Pat?
Yeah, I wouldn't, when I look at that x-ray, I wouldn't look at that and say the patient has marked facet arthrosis.
No,
in fact,
Pat, I agree with what Rick's philosophy is, because we've seen the same thing in the lumbar spine. If they have like maybe a grade 1, even grade 2 degenerative facets, if you unload them, they seem to do fine. And we've not had anybody who had to go back in on infusion because the facets were bad. With the Charité, we used to see a lot of people that would have degenerative facets, but by and large, we get them by with facet rhizotomies.
Right. Well, I know we talked about this at the Cedars discourse. Is the whole reason that the facet joints got evaluated in cervical arthroplasty studies was just a pullover from the lumbar studies. So the lumbar studies, the facet joints do seem to make a difference in terms of facetogenic pain. It just kind of got pulled over into the cervical studies just anecdotally. And I agree with you, Pat. I mean, good looking facets, stable. I think it's much less of an issue in cervical than it is in lumbar. And I think that's what we talked about at the meeting we had out in LA.
And just to be honest, when we started the cervical disc studies, I personally, and I don't think we really even paid attention to the cervical facets. It wasn't like, you're talking about 2004, 2005. We just didn't really pay attention to it. We're more concentrated on the disc.
Well, the only time you pay attention is when they're fused.
As the lone non-disc replacement guy from TBI looking at those x-rays and being a deformity primarily, is anyone concerned with the alignment of the cervical spine on that x-ray? Because that alignment just doesn't quite look right. He seems fixed forward. You've got kyphotic angles between 4, 5, and 6. I'd be concerned over time with that if he's 1 year out right now.
Izzy, I would love to show you this case from the beginning, because when he came to see me, he was a little bit kyphotic. And I did his laminoplasty, and he got more kyphotic. Oh, my God, this case, I just looked at all the pictures from way back in 01. And then over the years, he came back to straight. And I think that he probably, was reacting to his foramen being tight and everything being tight. But this guy, over 20 years' time, I can tell you, is that he actually was more kyphotic at the beginning than he is right now. And he's got such a stiff old spine, I don't think it's going anywhere. That's the reality. It's
you can always make his numbers look right with a lumbar osteotomy anyway. So,
right.
Okay, with that, it is 6:19. I do want to let everybody go and get their dinner, and I want to thank everybody. Great conference. Terrence,
great job, guys.
Thank you, guys. Great job.
Give us great cases.
And all of our audience,
Friday.
Good job.
Hey, and all of our audience, thank you all for joining in with us too.
Great job, guys.
Join us Friday morning for Journal Club. Anybody that
Friday
can.
morning, exactly.
All the audience out there and all the speakers, thank you very much. Enjoy.
All right, have a good evening, everybody.
Okay, good job.
Bye, guys.
Stay safe.
Thanks for watching. Hit the subscribe button for more medical content.